What do you do in a situation when a patient shows up in the ED and asks for things that you and I would both think are actually unreasonable things to do in the emergency department?
So, DeLaney, I think the first question we have to ask ourselves is really what's unreasonable and what isn't? Because I think that's in the eyes of the beholder in a lot of ways. And it's, to me, so situationally dependent. It depends on the reason why the person's asking, which I guess would make it more or less unreasonable. It also depends on what the state of my emergency department is, to be fair. You know, if it's an unreasonable request first thing on a Saturday morning and my scanner isn't backed up, my lab isn't backed up, I only have a couple patients, I am probably more willing to be unreasonable as opposed to a Monday afternoon where there is a 20-person queue to get to any modality of imaging, and any extra stress to that system feels like it's going to be the needle that breaks the camel's back.
One of the things I've really tried to do over the past couple of years is get out of this notion that I'm the gatekeeper for tests. Ultimately, I am, right? A patient can't order a thyroid panel themselves. They can't order a CT scan of their head on themselves. But I don't want them to think that I'm blocking them from something they need. And so this is one of these kind of techniques from the cognitive science world where never let them hear you say no. We absolutely could get that. Yes, that's a great idea. We could check your thyroid. We could do a colonoscopy if push comes to shove. What I really think we should do is get you seen as an outpatient. And I'll even tell them sometimes, I'm not trying to keep you from this. I just have to tell you that the way we're doing it right now probably isn't the best way for you. And we can look for other options. And it's a little bit of the shell game, but I think saying, no, I'm not going to do that. That, in my hands, always sends the conversation in one direction. It's not a good direction. But the yes and, yeah, we could do that. Let me look at some other options. I feel that that at least takes some of the tension out of the room. That's the issue, is what if you do your wonderful neuro exam, the best you've ever done, and the patient says, that's great, I still want this. Would either of you guys, if the test isn't harmful and isn't, immediately dangerous to the patient, are you going to send an angry, disgruntled patient out? Or are you going to say, all right, you win? I mean, is this your hill to die on?
Oh, Andy has so many hills to die on. It's impossible to know if this is actually one of them or not. Matt, it goes back to what we were talking about at the beginning. It really depends on what is the state of my department and what's the state of my hospital. If I can afford, and by me, if the system, the hospital, the imaging modality can afford to have it done, I'll certainly consider it and have that conversation. If it can't, then you know what? Sometimes that is the hill that I'll die on, because it's not just about that single patient. It's about all the other patients in the ED that I'm affecting too. And, I will take the pie is bigger than the piece, and you have to pay attention to the whole thing.